Welcome back, coders, billers, and healthcare pros. Look, today the stakes are absolutely massive because we are going toe-to-toe with the heavyweight champion of audit risks. Before we dive into this critical explainer, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Seriously, you do not want to miss a single part of this 20-part series. Today, in Part 8, we're doing a total deep dive into Modifier 59. If your practice gets this code wrong, man, you are looking at huge compliance risks and some severe revenue loss. So let's get right into it.
Right off the bat, the Office of Inspector General, the OIG, literally calls out Modifier 59 as one of the most misused and abused modifiers in all of medical billing. Now, why does this happen so much? Well, it's because the OIG actively targets this specific code for unbundling and revenue inflation. I mean, when auditors see a 59, their radar immediately goes off. They are actively hunting for practices that might be, artificially inflating their reimbursement by unbundling procedures that really should just be billed together. It's a super high-stakes environment where literally one wrong code can trigger a massive investigation.
So what exactly is it? According to the official CPD definition, Modifier 59 represents a distinct procedural service. Now, the absolute key takeaway here is that it's applied strictly to non-EM, that is, non-evaluation and management procedures. You basically use this modifier to clearly communicate to a payer, hey, look, this procedure or service was completely distinct or totally independent from the other services performed on the exact same day. It essentially acts like a giant red flag for independence in your clinical documentation.
And that brings us to its primary role, safely overriding National Correct Coding Initiative, or NCCI bundling edits. See, NCCI edits are designed to bundle certain procedures together to prevent overpayment, right? Modifier 59 safely overrides those edits, but, and this is a huge but, only when the services are genuinely, clinically separate. It is definitely not just some magic wand you wave to get a claim paid, it's a highly specific communication tool, and it requires absolute precision and undeniable clinical proof.
Which leads us into our next section, why auditors target Modifier 59.
Payers are heavily scrutinizing claims with this code, and there are some glaring red flags that will immediately trigger automated payer edits and RAC audits. First up, high-frequency usage. If your practice uses 59 way more often than your specialty peers, you're going to get flagged. Why? Because the OIG is always watching for patterns, and an unusual volume almost always suggests a systemic billing error. Second, payment outliers. If your reimbursement is unusually high specifically because of modifier usage, expect a knock on the door. And finally, the unjustified, repeated billing of the exact same procedure combinations. Using this as a routine habit without clinical merit is just a massive compliance risk.
Let's move on to section when to use versus when not to use.
Okay, looking at the valid criteria, you can safely use 59 for a different session or encounter on the exact same day, a different anatomic site or organ system, a separate incision, or a separate lesion or injury. Pretty straightforward, right? But in stark contrast, improper use, and honestly this is where billers get into serious trouble, includes appending it as a routine bypass. You absolutely cannot just attach it to get a claim paid without hard clinical justification. Plus, you should never ever use 59 when a more specific X modifier exists. Defaulting to 59, that's a really dangerous habit that auditors actively hunt for.
So, you might be wondering, how does this actually look in real-life practice? Let's take all this coding theory we just talked about and apply it to a practical, real-world clinical scenario.
Imagine a patient comes in, and during the visit, the provider performs an excision of a lesion on the left arm. Okay, that's our primary procedure. But during that exact same encounter, they also perform a completely separate excision of a totally different lesion on the chest. Because these are separate lesions located on completely different anatomic sites, you would append Modifier 59 to the secondary procedure, in this case the chest excision, to clearly show it's distinctly separate from that arm excision.
Up next, section, the documentation gold standard. Actually getting the code right is only half the battle here. Grab a pen, because this is your quick, actionable, audit-proof checklist. To create the exact medical record trail required to withstand a RAS audit or post-payment review, your documentation absolutely must do 4 things. 1. Document the exact anatomic sites. 2. Detail the specific medical necessity for both procedures independently. 3. Clearly prove the distinct nature of the services, like explicitly noting the separate incision or separate lesion right there in the operative report. And 4. Ensure absolutely no other X modifier applies before defaulting to 59. Remember the golden rule of coding, folks. If it's not thoroughly detailed in the notes, it didn't happen.
To wrap things up, just remember that Modifier 59 is a truly powerful tool to ensure fair payment for distinct services, but it requires exceptional documentation, and it should never be your default if a more specific CMS modifier exists. Follow that audit-proof checklist, bulletproof those clinical notes, and protect your hard-earned revenue. Thank you so much for joining me for this explainer. Keep your coding clean, and I will see you in the next one. Coming up next, in Part 9, the X modifiers, XE and XS, separate encounter and separate structure. Until then, ask yourself a tough question. Is your practice defaulting to Modifier 59 because it's clinically justified or simply because it's easy? Trust me, the auditors already know the answer.